Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will briefly present an article published in the June issue of Indian Journal of Anaesthesia. It is a randomized controlled trial to compare the efficacy of between the fingers grip with the conventional pen holding grip to hold the endotracheal tube for orotracheal intubation. As airway management is cornerstone of anesthesia practice, and there is known evidence of best technique of holding the endotracheal tube to facilitate the orotracheal intubation, a modified grip is recommended, which allows the operator to change the curvature of the endotracheal tube as it nears the glottic opening in a dynamic fashion during laryngoscopy. This will help to maneuver the tip and align it anteriorly with the glottic opening. It is claimed to provide better control and less external assistance may be required for intubation. So this is the classic pen holding grip which is used, and this was used in group C, whereas this is between the fingers grip which is used in the group M, that is the modified grip, where you can see that the ring finger and the little finger are placed at the lowest part of the ETT, and the ETT rests on these fingers. This point acts as the fulcrum. The thumb is placed at the top, whereas the index finger and the middle finger are placed in the middle, and they will provide the counter force to change the direction of the tip of the ETT to an upward and forward direction. The primary objective of this study was to compare the success rate of this modified grip with the standard grip based on the number of attempts and requirement of any external assistance in the form of backward, upward, rightward pressure maneuver, that is the burp maneuver, to perform the endotracheal intubation. The secondary objective was to compare the time taken for endotracheal intubation for each grip and to compare the hemodynamic parameters, that is the heart rate and the mean arterial pressures. Ethical approval was attained for this study, and the trial was registered as a BETI trial in the CTRI. It is a randomized interventional single center study which included participants in 18 to 60 years of age group posted for elective surgery under GA with endotracheal intubation with the Malampatti scores of 1, 2, and 3 and a CL grade of 1, 2A, 2B, and 3A on laryngoscopy. The patients that were excluded were those who refused to participate in the study, any anticipated difficult airway or a history of difficult airway in any previous documents, head and neck pathology, or hemodynamic instability. The patients were randomly assigned into two groups, the group M, which is the modified grip, and the group C, which is the conventional pen holding grip. The monitors were attached, IV access was taken. PVC ETT of 7.5 millimeter ID was chosen for adult women, whereas a tube size of 8.5 was taken for adult men. The induction was done with fentanyl, midazolam, etomidate, and vecuronium in all the patients. After the sniffing position, a single anesthesiologist with more than 10 years of experience performed direct laryngoscopy in intubation. If the patient was found to have a CL grade of 3B or 4, that was announced and the patient was excluded from the study. As per the group allocation, the grip of the holding ETT was decided. Another anesthesiologist with an experience of more than 5 years applied burp whenever required. A trained technician of more than 10 years of experience noted the time required for the intubation. The time was noted as the insertion of tip of the ETT between the open lips till the first ETCO2 upstroke in the monitor. The primary outcome of the study was to note the number of attempts, 1 or 2, or any external assistance required in the form of burp. Secondary outcomes were the time required for completion of tracheal intubation and any changes in the heart rate and MAP as baseline reading, which was noted before the induction of anesthesia, at the time of introduction of ETT tip into the mouth, and the time of appearance of first ETCO2 upstroke on the monitor. That is, 3 readings of hemodynamic parameters were taken. The required sample size was 121 in each group, and accounting for the possible exclusions on OT table after laryngoscopy, 300 patients were randomized in the study. SPSS 23's version was used for statistical testing. Now, total of 276 patients were included in the study, 133 in the modified grip group and 143 in the group C, that is the conventional group. Now, when comparing them on the basis of demographic variables as well as the airway assessment parameters, both the groups were comparable. Coming to the primary outcomes, the number of patients with single attempt of intubation were comparable in both the groups. That is, in both the groups, the number of patients who had intubation in single attempt were comparable, statistically comparable. Whereas the burp was required more in the conventional group, and the time taken in all the patients was also significantly more in the conventional group. The time taken in patients without the requirement of burp was also significantly higher in the conventional group. Therefore, when comparing the modified grip with the conventional grip, the burp requirement, the time taken for intubation, and the time taken for intubation in patients without the burp was significantly more in conventional group. Comparing the hemodynamic parameters, all the parameters taken at the 3 time points were comparable in both the groups. Now, therefore, between the finger grip is as good as the standard grip for orotracheal intubation. It seems better because lesser external assistance was required in the form of burp and less time was necessary to accomplish the intubation. Hemodynamic stability was maintained in both the groups. The modified grip allows the operator to change the curvature of the ETT as it nears the glottic opening by dynamically changing and aligning it to the glottic opening. It provides a better control and alignment than the fixed curvature of the conventional grip. Use of burp requires a second assistant, and the glottis or oral cavity is not visible to the assistant, and the assistant is guided by verbal cues. Therefore, this causes unnecessary delay and further deterioration of the view. The modified grip allows the movement of tip under direct vision of the person who is performing the intubation, and therefore the requirement for external assistance and time taken for intubation may be reduced. Further studies can be done in patients with anticipated difficult airways. Therefore, concluding the study, between the finger grips proved to be equally good method to hold the endotracheal tube for orotracheal intubation as compared to the standard method. Thank you so much.